I don't know if y'all are able to hear us, but the people attending virtually, we're
Can
not.
you hear me now?
Yes, now we can.
Okay, sorry. Something about this word called mute. I know it's a difficult ask when you don't even have a grid, right?
I think we comment already. Yeah. Okay. Yeah. I think that it's clearly in sinus tachycardia that will make us think about all the things that are going on there. Probably norepinephrine and things like that, and after resuscitation. But mainly we have to be very careful on interpretation ECGs after resuscitation because there might be a lot of things going on there. Not only the list of those drugs, which are very suspicious, but mainly that there is a myocardial injury, even if the resuscitation has been done perfectly. So we should be very careful, but take it into consideration for the future, because we all see this slight elevation of J point in, I would say P2, and that's it.
And that, in fact, was the case. His ventricular function, as you might expect, was moderately depressed for the first day. Before I get back to the history, this was his ECG 2 days after the arrest, when he was afebrile. And again, you have some notion that there's some J point elevation in B1 and B2. But right, it's very difficult to expect anybody to make much of this, especially when it's basically an incomplete ECG, because I don't have a grid, but this is what we had.
ಅದು ಬೇರೆ ಬರ್ತಾ ಇದೆ.
ಅಲ್ಲೇನ್ ಬರ್ತಾ ಇದೆ?
HRS, Heart Rhythm Society ಇದು.
Maybe I should go back to mute.
ಇದೆ ಹಾರ್ಟ್ ರಿದಮ್ ಸೊಸೈಟಿ ಇದೆ. ಬನ್ನಿ ಇಲ್ಲಿ ನೀವು ಹಂಗಾದ್ರೆ. ಅಲ್ಲಿ ಏನ್ ಕೇಸ್ ತೋರಿಸ್ತಾ ಇದ್ದಾರೆ? ಅದೇ ಅಲ್ವಾ ರೀ? ಅದೇ ಅಲ್ವಾ?
Okay, I just went off mute so you can hear me. Please mute yourself so we can't hear you until it's time for questions. Thank you.
So Ron,
what was wrong with a standalone microphone, a carousel with slides?
The good old days. Ron, I've got a question for you.
Yes.
Was he hypothermic at this point? Were they cooling him?
No, he did not get CNS cooling. He did not. All right, returning to the history. Coronary, I mean, this was in an adult hospital with no pediatric affiliation or really any EP affiliation at this point. Coronary angiography was performed. After he recovered, CMRI was normal as well. And on post-op day 9, he received an ICD. His past medical history and family histories were completely non-contributory. Genetic test was performed through in vitae, as you see there. And there was a heterozygous variant adjudicated as a VUS at the, I believe the,
I think it's supposed to be 428.
What?
Oh, just its location is.
So one of the things we want to do is to see how you guys think about this. So please think aloud.
I just did.
What are you referring to?
Mike whispered something.
Well, Susan was just commenting in that the annotation of that missense variant is glutamic acid at amino acid 28 heading 2 or being mutated to lysine. That's also what we call E28K, but you notice the nucleotide designation is 1282. So that amino acid designation is wrong because 1282 divided by 3 would be 400 and something.
Right.
Right. So whatever it is, it's 400 and something amino acid, and whether or not it matters. It's been observed in cases. So that gets back to what we were talking about, doesn't it? As to what does observing cases mean? What's the strength of those cases? The presence in database is problematic, right? Nomad at 0.001%. Nomad, if you don't know, is the genome aggregation database. It now has sequence information for most nucleotides in over 800,000 individuals. And so when you get that percentage, this is about 1 in 10,000 people. So in my notes, I'll refer to it as a pseudo population frequency, because Nomad is not a true population, but it's a decent one of patients who are not enriched for our world. So there's not an a priori enrichment in Nomad for any of our channelopathies, any of our cardiomyopathies.
Mike, I'm going to ask you to put it on hold because we get to you in just a few slides.
Okay.
And this will impact on the, I know. This will impact on the audience question.
Mike, when you talk, it's not being recorded. I have a clinical concern because the last sentence says the diagnostic of Brugada syndrome was made. And I have doubt on that. I don't know if it's a question for the audience.
Right.
Okay, it's another question.
Patience. Or we can move to the next case. So correct. The people on the outside made the diagnosis of Brugada syndrome. Interestingly, of the 3 children, 2 of them had the same SCN5A variant.
And this is a real world problem. I mean, this happens to us all the time. So I'm glad you're presenting this case. I think it's great.
This is terrible. We're stuck.
I'm blaming AJ's computer for this one.
Okay. I think we're going to be able to move on beyond this slide as well. If you agree with the diagnosis of Brugada syndrome, which of the above features is most compelling for this diagnosis? And if you don't agree with the diagnosis of Brugada syndrome, you're not going to raise your hand. The history. So the history of a VF arrest while performing a piano concert. Who believes that that was a consistent with the diagnosis of Brugada syndrome? Certainly not diagnostic.
And it just show up live, so I have it here, if you want to share it with everybody else. As people put in answers.
Oh my goodness. My goodness, you were on camera.
Oh, your computer shut it down.
Yeah, that's it.
Why are you shutting down?
We are doing so well.
Ron, you take over. You are so good at this. You don't need a computer. You don't need a presentation.
We need a carousel. All right. So we're going to get to each of these 4 points. The second is the ECG in the ambulance during low-grade fever, and this was already commented upon, right? That seeing a Brugada pattern, both in the presence of other pathology, medications, and low-grade fever is not entirely specific. And this was commented upon as well. We don't have anything right now.
AJ's computer is booting up if it wants to turn on.
Well, while they're getting this audio fixed, I mean, to follow up on Susan, I mean, I think we've all seen these kind of cases, and I think the setup to me matters a lot. We see this mistake all the time where, you know, we get anchored in a label and that anchoring traps you. So I would, like, I think what you're getting at, George, is to call this Brugada syndrome, we're waiting for a lot of other pieces to come together. Now, would I call this post-cardiac arrest, drug-induced fever-related type 1 Brugada pattern? Yeah, I could potentially call that, for which I want to explore and see, is that Brugada pattern persistent after resolution of the cardiac arrest and recovery of the host, after disappearance of this cocktail of polypharmacy, after normalization of the fever? And if after all that resolution, he remains to have a type 1 Brugada ECG pattern with normal ECG or with high lead ECG, now you're starting to recreate the scene and say maybe this post-cardiac arrest reaction was a pre-existing electrocardiographic substrate. But we've all seen how many patients post-cardiac arrest have gotten diagnosed with long QT syndrome because they had post-cardiac arrest QT prolongation, and their disease has nothing to do with long QT. But once that's the first documentation in the medical record and the ICU, you spend so much energy retreating from that, and it's much, much safer and more accurate just to describe what this person is displaying on the ECG rather than jumping to a channelopathy. And so I think being careful with that will save you and the family a lot.
And regarding the ECG, wouldn't you expect anyway incomplete right from the front as part of it? I always find that very interesting that people fix now so much on the date and there's no incomplete right from the front. Is that part of the diet?
Part of the diagnosis, that's really, that's interesting what you just said. Part of what diagnosis?
So for Brugada, because people say it's Brugada, but then I would say that other people say Brugada. Yes, but there's no incomplete right from the front. They aren't normal, despite Reader and a lot of other things. I would say that's not the Brugada.
Right, so you would be getting at, is the ECG even itself, should anybody be seeing type 1 Brugada pattern, right? And I think that's fair, but if we're starting with a label of Brugada syndrome, we should be first starting with a label of an electrocardiogram that may be consistent with drug-induced fever-related Brugada pattern. And I'm not commenting on the theta angle and so forth as to whether I would have even called that a Brugada pattern. I personally would not have.
Let's see what the rest of what do you think, Prince?
Well, so yeah, I'm gonna play devil's advocate here and say, this is a man who had a VF arrest, had the ECG we all saw. We can debate if it's type 1 or not. Was noted to be bradycardic after his arrest without hypothermia, and he has an SCN5A variant. I mean, I think, the Shanghai score is pretty conservative, but he would have enough points to have a clinical diagnosis of Brugada syndrome. I agree with everything you're saying. If this was only seen in isolation immediately after his arrest and you never see it again, it's not suspicious. You've got to be, more suspicious that he doesn't have Brugada. But I think at this point, I think this is probably Brugada syndrome. Yeah, go ahead.
George.
There is something very important is what happened. I mean, during a piano concert of a person who's a professional on that, this is not the real clinical situation that we would expect a Brugada syndrome to present with arrhythmias, right? It's not in a post lunch during at night or whatever. Of course, we have this little fever, which is important. It would be the only thing that clinically matches, but really during a concert, your adrenaline levels are high. So probably you are kind of protected against this vagal situation that would infer more arrhythmia.
So when I first met him, you're getting to the next slide, thank you. And then I want to definitely come back to the point you were making, Mike, as we include this. Mike actually saw this patient eventually in telehealth consultation. But to the point you were making, he volunteered when I first met him that when he's doing a concert and he's performing, he is as relaxed as he ever is in his life. He is zoned. He is just in such a state of nirvana that he actually tried to talk me into thinking that he's in this vagal state at this moment. I actually believe that. Well, fast forward about 6 months after he has the ICD in, during a routine remote monitoring, the device during the monitor zone identified a VTAC episode, which turned out to be sinus tachycardia at 180 beats per minute. And he and his doctor backtracked that to that day and hour, and he was giving a concert in Israel at that time. To your point. to your point.
Anjit, did you have a question?
Sorry, in the acute phase, did they do anything to exclude myocarditis from COVID?
Did this CMRI, which satisfied them that there was no inflammation or edema, the sorts of things that they expect to see.
Great question.
Yeah.
Okay. Next
Does
slide.
he medicate for the concerts? He's not somebody who
No, he does
purposely
not.
takes beta
No,
blockers?
he does not. Okay, thanks. So before I interrupted Mike, he was making an important point. I sent this information around to the SADS Medical Advisory Board and got a number of terrific responses, of course. And they ranged from comments about this particular variant and how it has not been shown to be associated with loss of function, maybe some modest gain of function even. Mike actually saw him in consultation at some point. And rather than me read from my slide, let me get back to the point you were making in terms of the variant frequency at this location.
So I think this is where Nomad has become incredibly helpful. I use it a lot. I rely on it a lot because one of the things that is in our favor is mathematics always rules the day and wins. So here, this specific missense variant, not convincingly implicated in a phenotype before, not convincing functional data. And if in anything, the functional signal is going in the wrong direction with a potential increased late current rather than loss of function. And then, oh, by the way, in Nomad, a database that's not enriched for our diseases shows that 1 out of 10,000 people of those 800,000 people have this said variant. And if you think about Brugada syndrome, at best, Brugada syndrome is 1 in 10,000, of which at best 20% have monogenetic sodium channel mediated Brugada. So at best, 1 in 50,000 humans are walking around with SCN5A mediated Brugada rather than 1 in 10,000 people having this exact variant. So this exact variant is at least 5 times more common than all of monogenetic sodium channel mediated Brugada combined. And so if you are going to maintain a position that this is Brugada, then we all start saying, yes, it's still Brugada, but with unbelievably low penetrance of less than 1%. And once you start talking to that level of non-penetrance, you might as well start saying, mathematically, this cannot be it, and move away from that VUS. And so we would demote this VUS in this person to likely benign. And in the absence of another owner out there who has a convincing disease mutation association, rather than saying it's a weakly penetrant variant, we would say this is a false call. Because remember, 20 years ago, we sequenced 1,000 healthy volunteers, and 2% of all humans have a rare variant in the sodium channel. 4% of all volunteers if you're Black. So just because you have something in a true disease gene doesn't make it an end of case. You solved it. This person had on stage piano Brugada triggered episode. So we would not assign much, if anything, to this specific variant. Say we need to keep looking for the root cause.
I want to emphasize that among the international experts who gave an opinion on this, there was a tepid but definite acknowledgement that this is, at least given the data that we have and the time frame that we have, as Prince pointed out, this likely is Brugada syndrome, although there was not agreement.
But I don't think, Mike, you're saying, I think you're just saying it could be Brugada, it's just not this gene. It's just not this variant. Yeah, it's polygenic or it's coming from someplace else.
Oh, right.
And it's not the ECG.
And to that point, I mean, there are plenty of reports, I don't know if it has been looked at methodically, that having J-point elevation from fever alone is well reported. That by itself is not a diagnostic of much of anything. Now, whether or not they have subtle loss of depolarization reserve that gets brought out from polygenic cause, we don't know. Whether they're a form fruit, something we don't know.
But even the worst ECG you show, you don't have a type 1 pattern, which is the only diagnostic ECG pattern that can.
Because of the amplitude, you mean?
No, I mean, I think it's a well-performed ECG, but I don't see the J point at the ST segment elevation above 2 millimeters.
That's what I'm saying. We don't have, I mean, we don't have a grid. We do have a,
Gut feel.
Yeah.
Okay, a question from the audience.
So if I were to approach this in real time without not getting biased by the views that you pose to the experts, I would think as the first question would be, is this even Brugada type 1? Do we have a drug challenge test in this, or did you consider that before we start discussing?
Chandra, you're the best. Remember, I'm seeing his kids. I'm not seeing this guy. I'm going to let myself off. Having established that the diagnosis of Brugada syndrome in the father is now in doubt, what would be the appropriate next step? And there's no one correct answer, or, you know, we don't have an answer yet. So how many of you, with a show of hands, would recommend that a treadmill test be performed, or some kind of exercise test be performed on the father?
On the father.
I mean, on the proband.
Yeah.
Okay.
Okay.
These are not mutually exclusive, by the way. How many would perform an adrenaline test on them?
Almost everybody.
If you're American and you're raising your hand, I don't know what you're doing.
Well, he freely goes back and forth.
Ron has access to Ackerman.
Yeah.
Raise it marginally.
How about repeat ECGs on the children, including high V1 and V2 leads?
Everybody.
Okay. How about ensure that an AED is always present for the children? Okay.
I think the lack of hands on the last one is really encouraging, because we have one patient. We don't need to make 5 patients yet. You know, we have one patient, the sudden cardiac arrest survivor,
And he has an ICD.
and he needs a very comprehensive evaluation with the test that you said. And if we are left with unexplained cardiac arrest, we don't have patients yet, but we have a collection of first-degree relatives who need some cardiologic surveillance. They don't necessarily need and no matter what we find, in fact, when we find nothing, we're going to also tell you to have an AED, because what we do to these families psychologically is incredible when we're sort of establishing them. We don't know what happened to your husband. We don't see anything wrong with the kids, but the kids, you obviously might have something wrong. So let's carry this AED around like an umbilical cord. And so we need to stay focused on the patient who matters, the cardiac arrest survivor, the relatives who matter in terms of a diagnostic workup. But if we're not finding anything, I think we should be giving the family the encouragement of great news, that we're not seeing a signal of disease in any of the children, which if we're still not seeing a signal in the cardiac arrest survivor, I acknowledge that's a little unsatisfying. We all have work to do to say, well, you didn't find the cause in my husband. How do you know that my children don't have anything wrong, since you haven't told us what happened to him? But
Which, depending on the family and the individuals, even brings up the fact, do you even want to create more anxiety by doing any testing on the children until you have more information on the father?
You need to test.
Yeah.
But you need to test. The thing is that I know that creating anxiety is something we should all avoid, but not screening is not a way of not creating anxiety. I think that screening, like with ECG, that's it. That's what it should be. But remember that not screening can induce a lot of anxiety. Right?
Sure.
I have a couple of questions from the audience or
But the
comments.
detective work that's actually more helpful, which we seldom do, is because we're in the pediatric, we capture and do something to the kids. But the most important individuals who need to be screened is this gentleman's siblings and parents, because they have age on their side to yield us a phenotype. Because the kids almost always never have a phenotype. And we're always stuck, but it's the siblings and the parents who might unlock what's going on. And we don't make the effort to get that evaluation done necessarily.
This man's brother was evaluated by Sammy Viskin, who I believe did an Ackerman test and was negative.
Okay, a question here.
So one thing I don't see on this list would be febrile ECGs, that you have 3 school-age kids who luckily or unluckily will get frequently ill. And that, I mean, a negative test wouldn't make you feel perfect, but it might make you feel better. And I think what Mike and everybody is pointing out too, that if you don't trust that SCN5A as being causative, then you can't kick out that 3rd kid that doesn't have it. So you really are still kind of evaluating and following those 3 kids, but not just saying, okay, you 7-year-old that doesn't have the SCN5A, you're clean. Like, no, we really don't think so. But I try to get febrile ECGs on these kids. I've gotten lucky once, but that's one thing I will tell them if you are febrile and can get to an ECG machine.
Yeah, I agree. I think that would have been a far preferable 4th choice instead of having an AED around, because I think you're right.
And not to be the total devil's advocate, but didn't Arthur Wilde publish that the febrile ECG pattern is predominantly in the sodium channel carriers? Not so much in the polymorphics or the other. And so I think, not that we know every sodium channel variant, but it might be less of a yield here than it would be.
That's it.
That the last slide, Ron?
Yeah.
What are you gonna do?
So what are you gonna do?
What you guys told me to do.
No, but what are you doing?
I'm not being cheeky.
No, but what are you doing with this family?
I told the father that I was going to get the opinion of the best people. I did. I have a good relationship with him. Yeah.
So he's protected, he's got his AED, I mean, his ICD.
Right.
And with the children, are you going to be serially testing them, or one test and done?
We'll get back to the dad. I mean, I think since he's already started on the route, even though it's a long trek up to Rochester from South Florida, I think he should finish up with Mike. And that it has been my recommendation. We just got to get the insurance stuff worked out. And in terms of the other 3 children, we're going to do exactly what the audience said. We're going to bring them in and just do ECGs. We're not going to do any more than that, but proper ECGs. And I'm going to test the family and see how difficult it's going to be for them emotionally to drop what they're doing and take them to a local facility where they can get proper ECGs during fever, because could be a hassle for some people.
Okay. Anybody in the audience have any other comments, any other thoughts? Yeah, Anna.
I just wanted to add the comment to the vagal tone during the performance, during the concert. As you know, Huja, or how do you pronounce it, Wang, she's a concert pianist. She did a couple of years ago, she wore the monitor, heart monitor and the blood pressure monitor during the Rachmaninoff, concert. And that was like the 4-hour concert and so on. So she and the conductor and the audience wore the heart monitors. And it's called something that is called rhythmic syncing. So if they were syncing during the performance, and actually based on their heart rate and the blood pressure, they could find out which parts of the concert, what was she performing. So her heart rates would go up to 170, 180. Her blood pressure would go under 150, 100, as well as the conductors, as well as the audience. So I just wanted to know, this is something interesting. So there is no vagal.
No, that's harmony. That's
stimulus during the concert performance.
Thanks.
I think with Balaji, I think I find these evaluations unbelievably frustrating and disappointing. The couple of observations I would have is that the evaluation of a cardiac arrest survivor is profoundly heterogeneous across the world. Many times the adults get done with them, they do a minimal evaluation, they have their post-cardiac arrest secondary prevention ICD, and that's it. There's no ongoing periodic surveillance. The adult is subject to a box surveillance. We'll routinely see you to make sure the ICD is performing, but people turn off the detective work for, well, what was that did that 3 years ago, 5 years ago? They're not looking for an endophenotype or a phenotype to emerge. And so we would keep this gentleman not in an ICD, how is it performing queue, but an every other year, every 3rd year phenotype surveillance mode, we would do one round of systematic, careful evaluation in the first degree relatives. If that's clean, we would probably do it again depending on their ages. So if we did one pre-pubertal, we would probably do another one post-pubertal. And we would be quickly moving towards dismissal of those screen normal first degree relatives. And there's encouraging data from Arthur Wilda that has shown that when you do these surveillance things in the other relatives and we find nothing, there's almost never, not never, but almost never a second close call or a second tragedy among a first or second degree relative. So I think these families are just so devastated by the uncertainty of everything. And I think we need to give them some of the silver lining that when we are not finding anything, there's actually a piece of good news in the not finding anything, which is the same whether it's a cardiac arrest survivor or a sudden death victim who gets the autopsy, who gets a postmortem genetic test, and we do a drill on the living. Not finding anything in a way is one of the better outcomes.
Yeah, Austin.
I'd love to get the opinion of the experts. You know, we talk about ruling out diagnoses after cardiac arrest, but with what you've seen, can you tell us what's still on your list? Even there's probably things I don't know, like there are rare diagnoses. I mean, besides like PVC triggered VF, it's gonna be hard to find, but other things that the panels aren't gonna capture. You know, there are certainly diagnoses that most of us don't know.
I think it's important that we don't have the cause, and we have to keep that in mind. But there are certain things that happen, like coronary spasm, that you can have electrolyte abnormalities, like transient electrolyte abnormalities. You are starting a COVID process, and you have fever, and maybe he was a little bit dehydrated because he was in a concert, he was sweating, so there are sometimes there are like kind of conditions that and reproducing.
Yeah, here, no.
Please, over here. Keep on, please. Is
Okay,
it white?
It's great.
Okay. Do it again.
How tight here?
So the thing is that sometimes there are certain conditions that there's no way to reproduce at the hospital, and we won't have that. But as Mike says, we have
Bye.
so sometimes we have to say, okay, this is unknown, and that's it.
And I think, Austin, you may be hinting at CRDS or like, you know, new diseases that, you know, 10 years ago we didn't know about. Yeah, exactly. And so we weren't told if this guy had sort of a full panel sent or if it was SCN failure directed. But that's, you know, that's one of the newer diseases that's out there that, you know, may not be on everyone's radar. Another sort of correlator to this point is like lots of times, you know, as Mike said, you know, they get an ICD and they're not thought about, there's no diagnosis, but lots of times they're given a diagnosis that's just wrong, right? It's somebody presents with VT, they can't really find anything, so they label them as ARVC or Brugada. And then you see the kids, and if you're told, oh, that, you know, the dad is ARVC, well, you're gonna start an ARVC hunt, when what you gotta do is actually look at the primary data on, you know, the dad, the proband, and say, you know, did they actually meet criteria for this disease? And if not, I've got to think of them more as the idiopathic VF. Perhaps, you know, recommend a more comprehensive clinical evaluation for the proband, and then, you know, do more targeted screening of the family. That happens probably just as much as the other.
What's the data on classic CPVT, ryanodine receptor 2 negative CPVT in a patient presenting at this age?
At this age, it's pretty unlikely, honestly, and in this clinical scenario.
Thank you.
Thank you. I think, thanks, Ron. Super quiz. Lots to learn from that. Yeah, we all have this problem. So, Tony, can you take over?
All right. I have a case, syncope in a 17-year-old during sports. Okay, no financial disclosures. Well, goal. What? Oh no. It's coming up. It's okay.
It's an own goal.
Go, keep going, go. All right, what? Oh no. So syncope in a 17-year-old girl during a high school soccer game. She was celebrating immediately after a goal. She ran up to her teammates, and prior to hugging a teammate, she fell into her teammate's arm. The teammate lowered her to the ground. Parents and bystanders did not initially recognize that anything was wrong. Teammates actually assessed the patient. They were CPR certified, found her to be breathing, and called to everyone for help, and 911 was called at that point. Patient recovered consciousness after 30 seconds and prior to the assessment of the coach and the trainer. The trainer's assessment was that the patient was conscious and breathing with a regular and thready pulse. No active resuscitation was performed, but patient was disoriented when EMS arrived, and so she was transported to a nearby hospital. Past medical history was negative. She was on no medications, had no prior hospitalizations. There's no history of illicit drug use, alcohol. She's a junior in high school. She is a competitive soccer player, however, and already accepted a Division I scholarship. And there's no family history of sudden cardiac arrest, sudden unexplained deaths. The father did have a history of multiple syncopal events with raising his hands above his head, which was kind of interesting historical feature.
Is that still going on, or is it in the past?
He had his last one several years ago, and it was really with deep diving that he reported that.
Okay.
Yeah.
His diving or yours?
Our deep diving.
Your
Yeah. This patient had no fevers and no illnesses leading into this. She did have a prior viral respiratory illness 1 month prior. She was not tested for COVID-19 or influenza at the time. She did report occasional palpitations for 5 to 10 seconds at rest. And she had one prior syncopal event while hugging her father about 3 years prior, but no prior syncope during exercise. And so this was her initial ECG.
Okay, let's stop here and see what both our expert panel and anybody in the audience thinks. Who wants to take it? Prince, looks like you want to take it.
So that's just a resting ECG, is that right?
Yes.
Yeah, so it's hard to see on this phone, but it looks like she's got a polymorphic couplet right there in the middle of it.
And it's starting late, like at the end of the T wave, the first PVC. And she's somewhat bradycardic, but she's an athlete.
Mm-hmm.
And does she have T wave inversions out through V3 or 4 maybe?
Yes, yeah.
Yeah.
And then this QT I measured and it's accurate, so we didn't consider it prolonged for a girl her age.
What's that number for those?
460.
Okay, thanks.
I'm curious, before we all saw this ECG, did you all frame your shortlist differential already? And of those who did, how many of you found yourself before you saw this thinking CPVT? Okay, this is going to be a great case because you should absolutely not be thinking CPVT from what we've seen so far. And I haven't seen any of these yet. So, but the reason I would say that is, when did she faint? After. That's interesting. And when does a CPVT patient show a bidirectional VT? Almost never at rest, like never at rest. And if they do, that might be not even their CPVT ectopy, but concomitant something else. And then that melts away and CPVT ectopy starts to arrive at stage 2, heart rate 120. And almost when it starts to arrive, never arises with bidirectional VT or bidirectional PVCs. And then Prince gave us a super hint just now with what he saw with the T wave inversion. So when I see a patient with this setup, I'm actually in my head thinking this is going to be in the realm of a cardiomyopathy, not a channelopathy. And so we'll see if I just walked myself off a plank.
And
But-
remind us, she did have a viral illness a month ago.
One month prior. Yep. Okay. Let's move on. So she was hypotensive during transport, had frequent extrasystoles, judged as PVCs. She recovered her mental status and there was no postictal state. She had initial labs which were normal and relatively unremarkable. She did have a mildly elevated troponin and an elevated D dimer. So at this point, I guess we can look at what is your differential diagnosis?
Susan, what were you thinking? You were just.
Oh, well, if not, there's going to be an audience response.
Yeah, you guys want to use your, it should pop up on your phone if you have done the barcodes, you can put in a response.
This, she did or did not get chest compression?
Did not.
Did not, okay. That's kind of important with that little piece of elevated troponin.
35% so for cardiomyopathy, 25% myocarditis.
And they're not mutually exclusive.
All right.
Can you get this much troponin elevation just from exercise, or is this too much?
Yeah.
So the troponin is another confounder.
May or may not matter, but.
Okay.
Okay, Tony.
All right, I think that was that question. So her initial echocardiogram was performed. It was significant for a borderline dilated RV, mildly diminished right ventricular function. They read it as desynchronous LV systolic contraction, and they did have normal proximal courses of the coronary arteries. At the outside hospital, a CT angiogram was done because of the D dimer, I believe, and it was read as no evidence of acute pulmonary embolism, but the radiologist at the outside hospital did comment on dilated right ventricle with trabeculated appearance, fat attenuation along the RV wall, and the coronaries were not evaluated at that CT. And so this is from the CTA, and so you can see a dilated or large RV. No, it did not. Yeah. So next steps, after the echo and CTA were performed, what other diagnostic would you perform next?
I think you're polling people. Still answering?
Okay. Well, I'll tell you that we performed all of the above.
Okay.
And I don't think that'll be too controversial. So she recovered and her troponin recovered in the hospital, but she had very frequent PVCs throughout the first several days. And then we did a stress test, a treadmill stress test, and she developed this at stage 4 and stage 5. Ironically, really, and I think AJ was there for this, was not symptomatic. I mean, kept pushing herself from stage 4 through stage 5 and only stopped when I think our team got, very nervous and their blood pressures went up. So this is what we saw on stress test. Does anyone want to comment any more on these?
Yeah, let me ask the panel, what do you guys think? Susan?
It looks like monomorphic ventricular tachycardia, and on our phone, we think it's outflow tract, but we can't see it that well. I would have stopped. This would have scared me. She was not really symptomatic. Like, she went from sinus rhythm to this, and
Yeah, and this was again stage 4. She kept going through stage 5 and she was alert, awake, and not symptomatic. Yeah.
at the end of the strip, we see that it starts not being so monomorphic. And I think that it kind of probably, if she keeps running, she will end up doing something else. Which is sometimes when you see those types of arrhythmias, you kind of panic, but you should not panic completely because you want to know if it just gets worse. But it's blackjack, you know. So, but sometimes it's good to be there and just keep calm because it's very important. Because if you keep with the 5 first beats, you end up saying it's monomorphic, but you will miss a lot of information if you make her stop. So, yeah, our coronary arteries just playing on us.
On the way to see the stage 1 and all, what was happening? Was it completely clean?
No, I mean,
The question was, on the way to the stage 4, was anything happening? Yeah.
Yeah, there was frequent ectopy, generally monomorphic ectopy that increased in frequency. I have those, but I removed them just for the interest of time. Correct. Yeah, the bidirectional, there really wasn't a lot of bidirectional PVCs. It was almost all this single morphology, and maybe and maybe 1 or 2 RVOT morphologies if there was another one. So. And then this was even in recovery. She kept having these, again, judged to be monomorphic at the time. We did a cardiac MRI, and it was significant for mildly dilated right ventricle with moderate to severe RV dysfunction, dyskinetic motion of the RV basal and inferior walls. There was a small aneurysm, and that's right here, an area at the RV apex, and then extensive nearly transmural myocardial delayed enhancement of the RV wall noted. And so you can really see that here, and here as well. And then my astute, oh, go ahead. MRI colleague who's very, very good, added this to his report, knowing the differential diagnosis.
It's surprising that the QRS on the basal ECG, the QRS is not that enlarged. I mean, you said that there was dysynchrony in the before on the echo, that there was dysynchrony, and you would expect some type of electrical dysynchrony as well, not only mechanical.
The stress test, I liked how you showed it, because before we were trying to say, try to have a pre-data shortlist established, and I would have been leaning away from CPVT. Then you see that the stress test doesn't look like CPVT at all, especially the recovery phase phenomenon. So we published a paper a while ago on pre-cardiomyopathic electropathic expression of ARVC. And Chris Simsarian published one of the earliest papers showing a sudden death series with structurally normal hearts. And in this case, this isn't a structurally normal heart, but what we observed was a lot of the ARVC patients pre-cardiomyopathy will give a stress test that will make you and I kind of think CPVT, except that there's more at-rest ectopy than what you would have thought. The during stress test ectopy doesn't progress kind of in the systematic fashion, but the key for ARVC stress test ectopy is ectopy in the recovery phase, which you almost never see in true CPVT. And when you see a disproportionate amount of post-stress test recovery phase ectopy, that's when you would be thinking PKP2 or desmoplakin. And statistically, you would probably bet PKP2 just because it's way, way more common. And yet the desmoplakin stress test, and one of our colleagues is showing a poster here, shows that the recovery phase ectopy actually looks much more like a DSP predicted individual. And so, and then with this imaging study, since it's pretty impressive right-sided involvement, you would be guessing, rather than predicting DSP, you would be predicting PKP2. The reason I would say predicting is because, again, what my new friend in Hawaii showed on losability, right? If you force yourself to try to make a pre-genetic test anticipation of the likelihood, that empowers your variant adjudication so profoundly. Because if you're sitting back thinking, this is really feeling like LQT2, or this is really feeling like CPVT, and then you get an RYR2 VUS, or in this case, you'd be kind of leaning towards PKP2 or DSP, but with an edge towards PKP2. Then if the company gives us a result, and if that result is labeled a VUS in the very gene that you were predicting, that's not a VUS. And so that's why I try to have our trainers force themselves to be thinking and committing to the differential all along the way, because that not only proves whether you're right or not, it actually improves your ability to adjudicate the variant.
So I asked Tony to put up this back again, because now that we have a better idea, anybody feel this is a abnormal ECG in terms of the T waves and V1 through V4? Or would you still say this is just a juvenile pattern?
Honestly, I would expect a more flattened T waves in inferior leads, 2, 3, and AVF. Seeing the MRI, I would expect having a flat or even inverted T waves in inferior leads, which I don't see. That's why it's surprising to see such an impairment of the right ventricle with this fibrose and this scar, and the aneurysm, the everything, and having this. Of course, it's an abnormal ECG, but you don't expect such a findings on the MRI.
Hang on. Is she African American?
Anglo.
Anglo.
Yeah.
Okay.
Not African, right?
Andreas.
Converted a little bit further out in African Americans than in white.
Yeah, but inferior, I mean.
the problem,
Talking about how it looks in the reporting.
but she's also an athlete, so you might, her actual normal ECG, if she wouldn't have ARVC, might look actually quite different. You know, I think she might have very high T waves without the ARVC, and she might have a large LV. I think the LV might be, I haven't seen the numbers, might be, usually you have a big LA, big LV in the athlete. So now everything looks different, but that's the pre-test might have been looking differently. So that's probably making it more difficult, I guess.
I think it's important, but it's very important to know that athletes do change the shape of their ventricles depending on the sports. So soccer players, I'm sorry to say this is not sports. No, yeah, it's a sports, but it's not cycling. It's not long distance running. It's very different the way they remodel the ventricle. A long distance runner compared to a sprint runner, and you can, without knowing which sports you are doing, you do the echo and you can tell that this is a long distance, this is a cyclist, and this is soccer player. And soccer player, I'm sorry to say, they are the less fit in the athletes.
Okay. I have a question for back to the CPVT idea. Is the site of origin of the PVCs, is this an atypical site for CPVT, or is there not really a typical site when you see these bidirectional couplets? Sorry.
So there's variability. I think actually Shu's group has probably done the most work on this, but the most common.
Speak up a little.
Sorry. So yeah, the most common morphology of the initial PVC is RV outflow tract, and of course that's also the morphology of the benign one. So that's not particularly helpful. But there is variability in that.
Shu, you want to make a comment? Okay, Andy.
I was just going to comment on this, and this is completely anecdotal, but you know, it's been my observation that when they're very athletic, and when I hear D1 athlete, you know, already, I have seen the juvenile pattern regress earlier in those patients. I don't know if they're maturing their heart faster, or again, I don't know if other people have noticed this or not. But if I see somebody and they have D1 anywhere in their history and they're still inverted through V3, I mean, that's concerning even just on a on a screening sports physical in my book.
That's a good observation.
That's a very good.
Thanks, Andy. And thanks, Mike, for making that point, because I remember about 10 years ago at one of AJ's sudden death conferences, I talked with Dr. Marcus, Frank Marcus, and he made an exact point about how the ECG can be the precursor, can lead everything before you actually start manifesting the cardiomyopathy. It's a very, very important point. Any more slides?
Yes, let's see. So my colleague commented on the Padua criteria, just really quickly with the MRI, we already had, and the morphology, we already had 4 major and actually 2 minor criteria, including the PVCs and the repolarization. So this patient, just by everything we've done already, really met a clinical diagnosis of by the paper of definite dominant right arrhythmogenic cardiomyopathy, clinically, even before genetic testing was performed. And so
The viral infection played a part here?
yeah, I'm
Did it turn her on, or was it a hot face, or?
I mean, she wasn't really febrile on admission, but she had a viral infection a month prior. So I'm sure that scarring was, present before that, though.
So in the interest of time, just give us the answer and keep moving.
Okay, sounds good. We started her on flecainide. We did a 14-day. Well, first of all, we restricted her from soccer during the phase. Okay, and you can imagine that this discussion was dad and patient. When can she play soccer? Well, is she going to play soccer? All right, she has a scholarship. What's like that was 10 of the questions per one medical question was about soccer. We restricted her from soccer in the early phase, started her on flecainide for the PVCs and ventricular arrhythmias. Her initial Zio patch had almost 10% PVCs, very frequent non-sustained VT, and a run of sustained VT as well, not with exercise. Flecainide was increased, and we repeated another ambulatory monitor that had increased PVCs but less VT. We repeated another treadmill on flecainide, and there were continued PVCs and non-sustained VT, and so we started her on Nadolol and increased that. So she's on Nadolol 20 and flecainide 150. And then the genetic testing came back after that. So maybe we'll stop here and discuss this result.
Any comments on the genetic testing?
And these guys can't see it quite as well.
Yeah.
So, okay, yeah.
So, I mean, based upon what we said and what we were heading up to, that this is why your phenotypic adjudication all along the way is so important, because if you did it that way, you don't even have to look at polyphen. You don't have to look at any of these in silico tools. This patient is PKP2 ARVC, not a VUS. You don't have to wait for the company to send an amended report 3 years from now to give you that upgrade, which they will eventually be able to upgrade based upon their collection of tools. So you have your diagnosis clinically, electrocardiographically, you have it genetically. You could guide, and it's interesting. I mean, even before knowing that, I think it was perfect that you did Nadolol flecainide. And if you look at Wojciech Zaryba's data and the ARVC, at a cellular level, there's a lot of mimicry in the calcium mishandling of PKP2 with CPVT. So it's not surprising that the treatment of choice for PKP2 ARVC is going to be Nadolol and flecainide. And so our approach with a patient like this is we would be trying to quote unquote cure her stress test with those medications, to up titrate them, to get a flecainide trough level stress test correlation, to find out what trough level do I need to achieve to get a pretty satisfying stress test. We also would be thinking about denervation. So it's turning out that left cardiac sympathetic denervation isn't just an LQT1 CPVT therapy. Basically, any lesion that has an adrenergic triggering to it can be very responsive to left-sided denervation. So we're doing that with our ARVC athletes who clearly have events. We're doing it with our filament C athletes who have exercise triggered events. And so the key isn't what is the genetic marker, it's what's the setting of the episode. If the episodes are adrenergic driven, don't forget denervation, even if the name of the disease is not called LQT1 or CPVT. So I would be thinking about that for her. The other big thing is prepping her for what her Division I university thing is. And saying that school that offered you that scholarship, they may quickly be dropping you. They may honor your scholarship. And so could we get her to a different university if they will say no, potentially? Would you support it? I would, since the nature of her sport isn't one where you would necessarily think that it would be disease agitating or disease promoting. So I could help support her stay a soccer athlete despite her diagnosis, which would be different than, like you said, if she were a Tour de France cyclist, you and I would probably have a hard time supporting that activity because we have pretty good evidence that that activity itself is a disease accelerator.
So I have a question there, and both of you commented on this. I'm surprised that soccer would not be a disease-provoking exercise. I would have thought that it would be, but tell me about that.
Yeah, I just don't think that the nature of soccer and the burst sporting of soccer, basketball, football, the on and off time is going to be as disease triggering. Now there is, as you know, the Hopkins group forever, they had a 0 dose level that if you are a positive PKP2 person, you are disqualified from life.
Yeah, we don't say that anymore.
So we're not doing that. And some are just very reluctant, but if you are PKP2 positive and phenotype positive, which she is, a lot of programs would throttle her down. A lot of programs would disqualify her. So we could have a healthy debate as to, is that appropriate or not, necessary or not? And I respect those who would say we probably might need to disqualify her. But if she told me that, look, this is my oxygen, I would be figuring out a way to let her keep doing soccer because I'm not convinced that this sport is the direct agitator. She could just as well have had her syncopal episode walking from school, potentially.
Right.
So I think it's sport dependent. I think it's passion dependent. If she was a Division III soccer player, then maybe this isn't really her oxygen, right? This is her activity, but she's already Division I bound, which kind of has declared to you and me how much this person probably loves this sport. And so we would be seeing whether it would be possible to keep doing it.
My question is, I think that's hard to say, meaning I just saw a soccer player with a Division I offer who also runs 14 miles a day as part of their conditioning. And I think her MRI certainly suggests that she's had a fairly progressive phenotype with her current level of activity. So I think I've found in my patients, there's a lot more crossover between conditioning and sports than.
Right, for sure.
Simply,
But you might alter their training regimen.
Correct. Yeah, exactly. I think you can try to target things.
Yeah.
But that's a very important point. The other thing that I would add to the treatment that because we haven't talked about putting an ICD on this girl, who would consider implanting an ICD to this patient? The thing is that if we are treating the arrhythmia, because she did all that without any medication, but if we are treating the arrhythmia, if we can clear the treadmill test, and even we would consider ablating the probably epicardial ablation of those focus of tachycardia, if there is one predominant foci for tachycardia, we would probably consider doing that ablation. Maybe we could consider not implanting an ICD in this patient.
Yeah, I agree with that.
Mike, can you talk more into the mic?
This substrate is just so unpredictable that I would be counseling her. We need an ICD, depending on if we were going to continue with sport, we would either give her an EV ICD or a minimally invasive epicardial ICD. And then we would be saying this may not be your forever strategy. that let's say we have success with nadolol and flecainide and we cure the stress test. And then she has no events, no nothing. Would we have to, is she committed to a lifelong ICD? No, so our messaging with our patients is this is a for now ICD, not necessarily a forever ICD. So we try to change our communication because many patients, once they get an ICD, they're envisioning in their mind that this is a forever part of their treatment package. And it may not have to be for those reasons, but would I start without it? I'm not sure.
But who is keen to take out an ICD who even once or
very hard to
another
take one
person
out.
has implanted an ICD?
Patients won't let you.
Oh, well, we have a lot of lists of
Really?
those who've had them removed.
Okay, sorry, Joe.
I was just wondering, what do you do with Cascade family screening in this situation? Where I work, funding wouldn't be approved because it's labeled as a VUS, although clinically we think it's pathogenic or likely pathogenic unless we pursue segregation testing or something like that. So I'm just wondering what's the practice or what's allowed in the different jurisdictions here?
It's very important that on the report, it says that this variant is not present in NOMAD, okay? So this lab, they put VUS because probably they have a wider range for VUS to put VUSs, but we can reclassify certain variants after our experience because there is a thin spot there for those variants that you really have a phenotype there, and really this is going to change in short time. So I think that this is something very interesting to discuss on certain reports, and we know that there are certain labs that they just everything is VUS, and we all know that.
So the VUS testing, we do VUS testing of the relatives all the time. And part of the issue that the other part that enables a VUS upgrade is actually the cascade testing, which drives me crazy when the companies say this is not amenable for, family testing or genetic counselors and all. They will not help support the testing of the relatives. So I do VUS testing of relatives a lot. We seldom have had that situation. So I'm wondering what is the issue of the not covered or the insurance. When it's not covered, the patient's out-of-pocket obligation is $200 max a patient. So getting that VUS answer, yes or no, in the first degree relatives has not been our big roadblock. So it's sorry that you're stuck with that roadblock. That's a big bummer.
So this goes out to the panel, and Mike, you already mentioned that by the fact that we have established a clinical phenotype, the status is already upgraded. We as the EPs that are approaching it, what's our responsibility to make that? And you said there is a lag for them to catch up and update their status. Can you elaborate that process? Why does it take for them to get to that point? What kind of do they wait for our clinical phenotype to be recognized, or what is our responsibility so that the rest of the folks who are going by a genome first approach are already aware of the fact that there is somebody with this, clinical phenotype?
It's really frustrating right now. That's the part I was talking to about the visibility study is maybe it would be better than having the VUSs in that repository is having all of the VUSs that have been clinically upgraded by us to likely pathogenics already, because that collection of phenotypically upgraded variants might be way more helpful for you to see, well, this has been upgraded. We used to report back to the companies and say, I know you called it a VUS, it's not, it's LQT2, or it's not, it's CPVT. They don't know how to receive that information, right? And to their defense, why would they care whether you and I call them up? They don't know on what basis we're saying it. And we're saying, well, we're making it on the basis of the power of the phenotype, we call it. But then their dilemma, the companies will be, well, what is the strength of the phenotypers? And how do we grade that to be able to assign a weight to it to say, if the garbage collector said it's long QT, we're gonna give it this weight. If you said it was long QT, in fact, you said it was not just long QT, but LQT2, we're gonna give it this weight to our algorithm. The companies in their defense, they don't know how to incorporate the strength of the phenotype in their algorithm. So they're stuck with their in silico tools. They're stuck with, well, this variant has now shown up 5 times in submitted cases and still is 0 in NOMAD. Well, now they'll send it the amended report because now they have mathematical evidence that this can't be just a VUS. So that's what they're waiting for. They don't know how to incorporate the strength of the phenotype.
Nobody's gonna publish these case reports,
Yanni, can I just ask you all to quickly comment on your expectations for disease progression? What's her heart going to look like in 5 or 10 years?
She's going to progress to transplant. And I don't
How
know if she's
soon?
going to progress with or without continuation of soccer. I mean, when a PKP2 patient has this impressive a phenotype before age 20, there is, I would say she has a 50-50 chance of progressing to transplant by age 30. I don't know.
Oh, I think she's gonna progress, yeah.
So I think that I don't speak just for myself. I think that a lot of people heads are spinning right now because of related to the comments of sports participation. Because this definitely flies in the face of what we have taken as dogma, which is probably inappropriate, right? Is there any human or animal data that looks at a more granular level besides the number of METs per week that helps guide what should be a cutoff for how we hold kids back from what they love? Or should we even be paying attention to that? Depending upon their, as you say, their oxygen. I have a comment.
Before I ask Mike again to maybe clarify, how many of you, if this was your daughter, would let her play soccer?
It's my daughter.
Yeah, if this was your daughter.
And it's her oxygen. So don't just say it's my daughter, because the first question is,
Okay,
do you actually love your daughter?
Yeah.
Okay. No, and seriously,
Yeah,
the
and she
second
loves
question
soccer.
is,
Okay,
is
she
this-
loves soccer.
We call it with our patients, every one of them, is this O oxygen or O optional? Because if they offer you O optional, of course, we're gonna help them to get disqualified. So you have to know more than just, is this my daughter and I love my daughter?
Okay, with all that.
You love your daughter and it's her oxygen.
Yeah.
Ask
yeah,
it that way.
Yeah, you love your daughter and it's her oxygen. You would let her play. You have a question or you're raising your hand?
No, you said vote.
We're voting.
Okay. I still don't see a lot of hands.
That's okay. Remember, 25 years ago, when we disqualified everybody, there was only a couple of hands in the audience.
25
But
years ago,
Mike,
we
how-
wouldn't have asked the question.
But Mike, how about if it's this young lady's 6-year-old sister who thinks she might like soccer and she's got the same genotype? And she has the option of getting into scouts and music and other things. Do you believe the animal and human data enough to say maybe we need to direct her differently?
Yes, so I think that's really, really important. So if I am now have a 6-year-old PKP2 positive person who's normal, because they're pretty much always normal at age 6, what do we help parents guide them towards? And so would I help them guide them towards marathon running for the 6-year-old? Absolutely not. Would I tell them that this child can never do any single sport ever and can only take up knitting? Absolutely not. So I would tell them we have evidence that the endurance training type sports are disease triggering for PKP2. I think we can say that now. Not they might be in mouse and in humans, they are disease triggering, disease promoting, disease accelerating. What we don't know is that statement that we're pretty sure is true for long distance cycling, running, rowing, et cetera. Is that true for a baseball player? Is that true for a football player, a wrestler, for whatever? And our approach would be, we let them do those activities that we're not sure. And if phenotype emerges on our annual surveillance, we might need to now alter our guidance and counseling. We might now need to throttle you back or adjust something or change something. But we have kids who once were PKP2 positive 6-year-olds, who are now in the NHL league. And they're still PKP2 positive. They've always been. And they happen to be still phenotype negative. So until we know who's the penetrant one, we don't know that they're going to convert. And the overall penetrance for PKP2 disease is at best 50%. And so we would watch them. We would probably maybe guide them, but we wouldn't just restrict them as the 6-year-old and say, well, you're confined to, like the patient I saw last week whose pediatric cardiologist said, you will be a couch potato from here forward. And when you head to the school bus, walk. And that's a patient with hypertrophic cardiomyopathy who's mutation positive, echo normal. So this messaging isn't like 25 years, we're still giving this messaging.
But we are so much better at it than the hypertrophic cardiomyopathy or the cardiomyopathy folks. I think they're way more restrictive when I talk to them in clinic than we are. I think we're really out there in the forefront compared to a lot of them.
Channels, yes, HCM back, they're competing again now with the examples that we have, but ARVC, and that's why we're doing Live ARVC. We actually need to get data as to in which genotypes is there disease acceleration, when and how. And so we don't have a lot of data, true data, beyond saying we're pretty sure that for PKP2 disease, long distance endurance training activities is a disease promoter.
But we don't know that that's every single patient with that.
Exactly.
Okay, I want Prince to comment and then I want Shu to
Just a minor comment. I think some of this is regional. I'd say in the American Southeast, soccer is like the most prevalent endurance sport. You know, we don't have a lot of cyclists or whatever. The handful of ARVC kids who present with syncope or arrest that I've seen tend to be soccer players. Yeah, so that's why soccer. I'm surprised you guys are like, oh, soccer's fine.
Well, I'm not saying, oh, soccer's fine. I'm just saying, oh, soccer may be better than knitting.
Yeah.
So, yeah.
Okay, I come from Barcelona. We play soccer a lot. And the echoes are pretty different that endurance is.
Sure.
Fascinating discussion, and I think everyone's pointing out that we're very, like, we're not great at phenotyping. We're terrible at phenotyping exercise load, and a reminder that almost all of the data is inherently biased by old people showing up saying, yes, I used to exercise. And someone recently told the story that, some 50-something male talking to the young genetic counselor, researcher, female is going to totally uptalk the one trophy he has on his shelf. I can't take credit for that story, but so the data that we are making these life-altering decisions on is very borrowed from other populations. So prospective registries, we've heard the R word a lot today, but like actually taking the genotype positive, phenotype negative children and learning prospectively, I think will be helpful. Dominic Abrams has done some work in this space, and the penetrance, especially in PKP2, is exquisitely low. So, our practice is if you don't have any phenotype, even if you're PKP2 positive, do what you love. Mike and I sat through some phone calls with mostly adult people writing our 2019 document, and they made statements like, just direct your child into something. And I don't know how many of you are parents that have actually successfully directed your child to do anything, but I want to learn from you how you did that. We can talk after the session.
Wow, fascinating session. Any last minute comments before we take a break? Okay.
I just wanted to discuss another aspect of sports participation in a patient with like this. I had a similar patient, PKP2 positive, presented with sustained VT, converted, diagnosed. MRI was not that bad. His function was in the 50s. And we decided to put an ICD in because during EP testing, he got a very fast, unstable VT. So we put an ICD in. He was a soccer player. Soccer was his oxygen. So he went back to play. And he went into VT VF storm. So not just disease progression, but real risk of dying during sports participation. So that's my question to you. about allowing these patients, or at least telling them, you are at risk?
Yeah, I think it's really important that they understand that their return to sport doesn't imply that we've given them the you're cured and nothing bad is ever going to happen. I mean, our notes state the patient, the athlete, their family understands full well that despite the return to sport, they may die suddenly. Their AED may fail to rescue them. Their ICD may fail to rescue them. So I think when these patients, the families that we encountered, and we've done this a lot, as you know, with a lot of athletes, they're not naive about this. I mean, remember, it's the mom and dad who's letting them go back to a sport where you just finished telling them that they could die suddenly when their child returns to their sport. Now, I don't necessarily see the families that quickly decided that this is nowhere close to oxygen and this is optional. They probably aren't coming to us to get requalified and reinstated. What I'm seeing are the families where that disqualification ruined them. And so maybe those families where that's been taken away from them, they understand the score, they understand the potential that they could be burying their child. And they supported their child going back to soccer to try to make it to Division I soccer. The families that we have don't necessarily think that their child is their ticket out to the next 2, 3, 4 socioeconomic tiers above the one that they currently reside in. We just have not had that experience.
Thanks,
We
Mike.
have not had a
Last
death
que-
yet.
last
I mean,
question.
It's going to be awful when we have the death of our first athlete that we supported his or her return, right? But that outcome should not change the fundamental correctness of this shared decision-making interaction. Now, if you return 100 athletes and you're 100 for 100 them dying, then maybe that outcome should alter your shared decision-making size up.
Okay, last question.
Tony, did you end up putting in a transvenous, I'm over here. Did you end up putting in a transvenous ICD or what did you put in?
I did for anti-tachycardia pacing capability.
Okay. That's why I was going to ask, did you consider a sub-Q? And then with
We
the
did,
transvenous,
yeah.
did you worry about having issues with sensing given all of the scarring in her right ventricle?
Yeah, but we ended up getting good numbers and it's been okay. Yeah. So this is I guess our last audience response question. I think we already asked, but would you let her play competitive soccer? And I'll tell you, this is what I did. This is word for word from my note. So I did also talk a lot about the risk of this being likely harmful to her in the long term in terms of her disease progression. But you know, this is exactly what I documented using the shared risk approach. And we just happened to be lucky that this all happened last year at HRS when the 2024 document came out. And so I went through this kind of point by point with the family of everything that we were documenting in terms of informed consent and allowed her to play. And a year later, she finished her senior year of soccer. And just how things worked out, her scholarship changed. She ended up getting into a better school than the school that she got a soccer scholarship to. And so she decided on her own to not continue to play soccer at age 18. But we did let her get through her senior year and have a great senior year of soccer. So.
What audience response? 75% said no, and 25% said yes.
Okay.
Well, thank you all. So we're going to take a 10-minute break.
Okay, for the online audience, very quickly. PDA ligation surgically back in Russia. First medical encounter in the States in December 2014 with fine atrial fibrillation that was successfully cardioverted. We saw the junctional escape EKG and there was thought for pacemaker. Holter monitoring was done that did not show any recurrence. However, during her office visit in September 2016, she was found to be back in atrial fibrillation. And so she was cardioverted at that time and a dual chamber pacemaker was implanted.
Can you go back to that ECG? Anybody have any comments on this ECG other than its junctional rhythm? Have you ever seen sinus rhythm in her?
We don't have a 12 lead of the sinus now at that time.
Did you do a Holter at that time at 11?
After this cardioversion, yes.
And did it have sinus rhythm?
It did have sinus rhythm beats. It had one ATAC of like 4 or 5 beats. And the baseline rate was between 50 and 60, but she was asymptomatic.
What was the predominant rhythm?
I don't have that with me.
Okay.
It was just a 48-hour.
Echo was normal?
Echo was normal. Up to recently, cardiac MRI is normal.
Anybody thinking atrial standstill here?
Yes.
Because I am. Okay.
So we actually have a question pertaining to this moment.
So going back to the pacemaker implant, is your mentor here who put the pacemaker in? Okay, what was the atrial threshold? At the implant, was it hard to pace the atrium? No.
It's excitable because there's retrograde induction.
Not necessarily. I know you can see it, but that doesn't mean it's excitable. Excitability is different from conduction. I've had patients with atrial standstill who have atrial flutter, for instance. So they don't necessarily have to go together. Yeah, and she has fib too. Okay, in the interest of time, give us the answer and keep going.
All right. So this is mainly, I'm going to come to the answer. So we do have a 12 lead with atrial pacing. And we noted that she had a very short QT, measured as 318 milliseconds. And so this was, we got genetic testing based on this, and it was positive. Additionally, pacemaker interrogation demonstrated these findings of one episode of non-sustained VT. They were very fast, and the atrial tachycardia that I had mentioned. So with this mutation of KCNQ1 valve 141 with methylene, what would you do next at this moment? Would you follow up clinically? Would you restrict from competitive sports, soccer, cycling, all of the above? Start quinidine or upgrade device to defibrillator now?
Anybody? Not just the audience. Any experts, any thoughts on this? Prince, looks like you have a thought.
I think this is the classical case that we know that our group described long time ago, and I think, and actually it's the same variant, and I think that what we've learned from all those times is that at the beginning we were very, very scared. But in fact, it's how do you perform with this bradycardia, what it makes the difference. And of course, there are certain cases that end up with sudden death, but is this sudden death related to bradycardia rather than the fact of having the short QT? So I think that being able to control the rate with the pacemaker, it's very, very important. How important is quinidine here? Well, it's a way to also control and try to homogenize the electrical performance of this heart. And of course, competitive sports would not have a big role here. So we should not be that restrictive. Actually, a little bit of tachycardia is good as well. And the fact of doing the upgrade to the defibrillator is always difficult. Because you have a device in, so should you put a defibrillator? But by using a defibrillator, your lead is not in the best position if you need a chronic pacing. I would just try to do atrial pacing as much as possible here to try to not manipulate the ventricle too much, like to stimulate that ventricle too much. And we use the pacemaker also to see the follow-up of that patient. It's a way to monitor and have a registry of any type of tachycardia, that asymptomatic tachycardia this patient could have. And
Set the atrial pacing rate, the lower rate at.
probably 80. Yeah, probably 80. But it will depend on how the patient performs. And of course, at minimum 80, and I would see if the patient needs a rate control, so to be able to do an AAIR, or if the patient has the own sinus rhythm by itself when it has more adrenaline in the body.
Yeah, so I think aside from the restriction from sports, any of the other options are very reasonable. I probably would vote for quinidine. She's had some non-sustained VT. She's had clinical AF that you've had to cardiovert. And when you start quinidine, you can see if she'll tolerate it. I found about 1 out of 3 patients cannot tolerate long-term quinidine. So you'll get your answer to know if that's going to be a long-term option as well. I wouldn't necessarily upgrade to an ICD just yet. I'd start with quinidine and then kind of keep that in my back pocket.
I have 2 questions, Prince, for you. 1 second. If she doesn't tolerate quinidine, what is the alternative?
If she needs something, then sotalol would be the alternative.
Okay, and if I agree, no ICD, what about an AED? Would you say AED yes to the family? I mean, where would you put the risk at for sudden death in terms of the incidence?
Yeah, we don't have a good answer. I mean, honestly, there's not enough data in short QT to do any real risk stratification, except people who've had an arrest, obviously, are enough risk.
Mike.
An AED is reasonable, but I would not, say it's absolutely mandatory.
Fair.
Could I, yeah, on the 80, but on the pharmacotherapy options, why are we so interested in still using quinidine and then sotalol? Because pharmacologically, that doesn't make any sense to me. So for our short QT patients, why aren't we using dofetilide?
Dofetilide, yeah.
If you thought of which drug made the most sense to try to, well, certainly to counter short QT1, she has short QT2, but to counter short QT1, which is gain of function of IKR, use dofetilide. The same idea, though, is to do that for this, but I haven't seen any papers really talk about a trial of using, because sotalol, why have the beta blocker activity of sotalol for our short QT? So I want to use dofetilide.
Yeah, no, it's a great question. I don't have an answer for that. There is pretty reasonable data on quinidine, both on the QT prolonging effect and reducing both AF and VT. So I think that's, of all the drugs we have, that's the one that has the most data. And yes, sotalol, most of the data is in KCNH2 mediated short QT. So it's not the right drug for, this patient. And I think dofetilide is probably a very reasonable second-line drug.
The thing of tolerance of quinidine is also that if you need to give it 3 times per day because you don't have the retard dosage, maybe you tolerate it gastrically, but you don't tolerate it for your real life because you don't want a patient that it's erratic in taking the medication. This is the most pro-arrhythmic thing you can have, to give an erratic dose of an antiarrhythmic drug. And I think this is very important to know that taking a pill 3 times per day, it's kind of difficult. Concerning the AED, then you need to put someone who is on call for that patient while sleeping, because AED has some type of sense, because in long QT that you take that AED at the field when the patient is running. But when the events are bradycardia dependent, so when the child sleeps, it means that you need to put some type of monitoring, or someone has to be next to this child while sleeping one night after the other for the rest of the childhood. So probably AED is something that it's a peace of mind having an AED at home, but someone needs to decide when it should be used. And this is a type of advice that needs to have a certain logics in order to take it to the real life, probably.
So I think, for the sake of time,
Two quick practical comments on the decision. So one, the pacemaker needs to be in for a very short time. I don't know what the decision. Oh, sorry. So two practical things about the ICD decision. One, the leads were quite new, and I actually thought if I'm going to change leads, maybe this is the right time. And in fact, the lead came up pretty easily, and I put an ICD lead. And two, very importantly, the parents really, really wanted an ICD. And I did not think and this is a decade ago, could say with enough certainty to kind of push for anything else at that point.
Great points. Okay, go ahead.
So she did well after that until February 2024, when she presented to an outside hospital after sustaining ICD discharge. She was seated at that time, not doing any physical activity. And unfortunately, we don't have the ICD EGMs, but they thought it was due to rapid atrial fibrillation that caused this based on their evaluation. Unfortunately, the referring providers wiped the device interrogating capabilities, so we couldn't review that personally. They had tried several antiarrhythmics, including dual defibrillation shocks, and they were unsuccessful. She was noted to have significant bradycardia with increased ventricular pacing burden. And these are two EKGs, first one at a rate of 60, and this one at a rate of 30. So at this time, that's when we got on board when they reached out to us for management of the atrial
Sorry,
fibrillation.
can you go back one slide?
Is their atrial lead not
Yeah,
working now?
is the atrial lead working now? Are you able to base the atrium at all?
So
Or
this
has
was
it
in
progressed to standstill?
during AFib, because she
Oh.
wasn't able to be converted.
So you're not converting at all, so you can't base.
No, we don't have the atrial electrogram for when she was in AFib presenting.
But the AFib's
Yeah, I don't know if AFib is the right term for this. I call it atrial torsades. That's what I've seen. When you put a lead into the atrium and you actually can get the electrogram off it, it looks exactly like torsades.
We have, yeah, when we take her to the lab, we will show the truth.
So the intracardiac ICD, it was very fine.
Yeah.
There were some applications.
It's faster than 50 cycle. Yeah, go ahead.
So how would we manage the atrial torsades in this case? She has a low rate, so she's kind of pacing dependent. We don't want, conventionally, she's a young patient that we don't want to leave on pacing. We have conduction system pacing available now. And then the other ideas are considering an ablation, either a combination of catheter and surgical or individually.
And
Anyone?
she's not on quinidine, correct?
She is not on quinidine.
And could it help now?
We have a fifth option.
Have you mapped her like not?
So you're offering taking her to the lab, EP lab.
Well,
Right. With option one?
yeah, well, the question has been.
Uh-huh.
the step, the
Okay.
substrate for progressive atrial stents, so it's not, that's not already happened.
Uh-huh.
You're just establishing that and then move on to the therapy. Don't have to take it to the lab for that, because that's a switch from the atrial lead.
Yeah. So the atrial lead was working and you could see electric. Okay. Okay, next slide.
So the referring center on atenolol and anticoagulation, and the decision was made for ablation. At our center, we have a minimally invasive approach to epicardial ablation, termed the CONVERT procedure. It's a combination of epicardial and endocardial done in separate times. So she first starts with the epicardial ablation. At this point, she was in persistent AFib 4 or 5 months. And here we have images. Okay. So we can see here, this is the ablation AtriCure. And here we have the at the location of the transverse sinus. We can see how the ablation lesion is occurring. And similarly, at the left atrial appendage base, we can see the lesion here. These are our maps showing after ablation, the scar. And you can also see here the ablated epicardial tissue. After this, despite amiodarone, she was still not able to be converted to sinus. 6 weeks later, as was planned, the patient presented to the lab for endocardial ablation and still was not able to be cardioverted. We performed our mapping, which demonstrated, complete scar and lack of EGMs in the posterior wall. So we proceeded with pulse field ablation of the pulmonary veins and posterior wall. And here we have the intracardiac EGMs. So we can see in the surface EKGs, the fine atrial rhythm. And you can see this is and then here we actually have the cycle lengths showing that these are very fast, with a cycle length of 35 to 55. It's notable that this is in comparison to regular or conventional AFib having a cycle length of 100 milliseconds. This is much, much faster. I just want to note, I think it's covered here, but this was at the LA roof, left atrial roof and lateral wall. So after completing that ablation, she was cardioverted, but actually went into an atrial tachycardia with a cycle length of 131 milliseconds. And so we chose to map this. And at this point, the map demonstrated a focal point on the septum. And so we wanted to make sure, is this from the septum or is this from the right side? And so we wanted to go to that, to start mapping that area. However, with catheter manipulation at that point in the right side, the tachycardia broke. And so we opted for, she was tolerating the procedure well. We were there. So CTI ablation was performed and she was, remained in sinus rhythm post-op and was sent on sotalol. And, with 8 months follow-up at this point, she remains in sinus rhythm.
Atrial.
Atrial-based rhythm.
Thank you. So in summary, this patient was gene positive for short QT syndrome. She had sinus node dysfunction. She also had a, refractory atrial arrhythmia despite several drugs and cardioversion attempts at this point. And so, we pursued the convergent procedure, and as of now, she, remains out of AFib, and we look forward to seeing how she does. I think we'll end there.
Great case.
Back to other channelopathies, sodium channelopathies that result in progressive standstill and extensive scarring. Do you think this will be a durable effect? What do you have offered so far? Like going to the extent of conversion?
Yeah. I mean, I think we have to think about what tools we have at this moment. And I think the best tools we have to have a sustained treatment for atrial fibrillation is the surgical epicardial isolation in the posterior wall. We demonstrated that there's no EGMs with mapping. That was about a month after. There have been reports, pulse field needing additional lesions later on or combination with RF endocardially, but time will tell.
Prince, are you, what's the why? Why is an IKS gain doing such a profound atrial myopathy?
No idea why, honestly. I mean, so
It doesn't make sense.
we know that SCN5A causes fibrosis, long-term.
Right.
this is the first I've heard of IKS, resulting in such atrial scarring. And so I have a couple of questions. So she had a couple of episodes of AF earlier that were apparently cardioverted fairly easily. And this one, do you think it was because, was it not discovered until she had been in it for several months, or did they try cardioversions early? And then secondly, did the cardioversions fail because, it was true failure to defibrillate, or was it, you get out of AFib and then your atrial standstill and it starts again, and maybe you don't know that, but I just have questions about that.
Well, since she had the device, we were monitoring her atrial, the referral center was monitoring her atrial arrhythmia, and there was no recurrences. So it was assumed that this was a very short length of time that she was in this. And we did notice previously that she would normally be very slow, but she would have bursts of where she could go very fast atrially.
I guess the one thing to add is just in terms of the scarring, the only scarring we found when we went back in was where we had done the epicardial ablation. The rest of the atria was healthy.
Yeah.
So it was really just the epicardial ablation was scarred. We completed that with the PVI, and everything else looked pretty good. Yeah, as far as the sinus node dysfunction, I'm assuming it's related to the ion channel. It was not excessive scar, at least when we mapped.
And we even had a cardiac MRI before any ablations that did not show any scar.
So it's just a question about the PDA. Was it very large? Was the atrium very dilated before the PDA ligation, or?
So it was done in Russia, and we don't have those records. But at this point, structurally, she was totally normal.
But it's important to take into consideration that those cases can be ablated. Normally are advised to be ablated by people who's used to ablate atrial fibrillation, the normal atrial fibrillation from adults. This is a atrial channelopathy, or expressing in the atrium. And it's not the same mechanism as atrial fibrillation seen in adults. So the procedures we perform normally will, maybe we succeed in ablating, doing the ablation and doing the isolation, but the arrhythmia comes from another place. So at the best situation, we will have atrial flutter that provoked by us ourselves because of the scars we have performed. So I hope you have very good results, but our experience on ablating atrial fibrillations related to channelopathies is that then we start having super difficult flutters. We have other atrial fibrillation, other type of atrial fibrillation. We can see that the underneath rhythm from the atrium is absolutely different. Sometimes we even see it coming from the superior vena cava. So really it's because it's not the typical pulmonary vein atrial fibrillation. So, but we apply techniques and treatments meant to be for that. And
So
we have to be really careful on that.
So you would keep her in the, or how would you approach then besides ablation? Would you keep her in AFib, which a lot of case series have left the patient
Yes.
in?
Probably yes.
And now that we have left bundle area pacing, we can at least pace.
Yes.
Because there have been heart failure in cases where they've been just VVI paced.
Right.
This question I put with the panel, we actually only have one, the baby with one prematurely, with late fetal bradycardia came up with very severe, had the same exact B141 yet. But we started recognizing the TARC mutation a little later. Only receiving she goes into upper process, significant cardiac and we have a family that is still a BD, that is still functioning. We have already accumulated a lot of baggage from gut loss and everything. So we're not still in a position to offer a pacemaker. So I'm wondering what the trajectory is going to be. Do they all, even the same variant, do they all behave similarly? Or at what point do you anticipate other phenotypes like AFib and all that can be?
It's variable, and we can see it, and it's mainly it's the bradycardia that will give you all the problems. But we have we did the series for all those patients, and we have 2 deaths related to dilated cardiomyopathy. Even though they were resynchronized and we put the 2 leads and so on, they end up dying on dilated cardiomyopathy in a stage that they were in least transplant, but they did sudden death by that moment. So both exactly the same.
George,
Okay, we'll turn over the cases while you guys keep talking.
I've got a question. So what do you make of that focal AT? So I can imagine that, AFib is just the correlate of, VF. But we don't see monomorphic VT in short QT syndrome. Do you think that focal AT they saw was just sort of,
They did not manage to reinduce it. Sometimes you just have it because you need to reinduce and you put isoprenaline or you put some type of
So more
drugs
artifactual
that-
than a-
Yes,
okay.
and you induce tachycardias or appear atrial tachycardias that you never see it again and you cannot induce it at.
Who? Chris.
Yeah.
Well, I think you achieved a great result, at least temporarily. We'll see. Yeah. Surprising. Did you feel surprised when you came out of the lab? Yeah. Can I ask you, was the patient symptomatic when you took them in?
Not necessarily, well, just the inappropriate shocks.
But if somebody hadn't been shocking the patient would have been just living okay? Yeah. Anticoagulant, yeah, rivaroxaban, they said. Yeah. Huh. Interesting, yeah.
To that point, you worry about, especially with so much extensive ablation, loss of vagal transport.
Yeah.
Probably wouldn't matter with normal ventricular function, but with getting associated cardiomyopathy. I think the adult world is being face this with total field ablation, where you're taking out the whole back of the left atrium and off the root. I don't know if you worry about that at all, but I'd be reluctant to stop.
Interesting. Are you guys ready?
Yeah.
Okay.
All right.
Next case.
Hey, thanks everyone for having me. My name is Shankar, I'm one of the electrophysiologists
The
at
slides aren't
Cincinnati
showing on
Children's.
Zoom.
What's that?
You're not showing up on Zoom.
Okay.
Just 1 second.
Okay. Yes, I think that's shared now. Thanks, Alejandro. All right, so this interesting family that I now followed for about 4 years. So it's like 3 patients in it. So I think it might be useful for everyone to kind of listen to all the 3 patients before commenting, which I think would be useful. So the first proban was a 16-year-old female with no prior history. So family was a refugee from Ethiopia who collapsed at home. She had no prior recent illness, was not active, and had just interacted with the family 10 minutes before being found collapsed. She had a very prolonged downtime and was in VF upon EMS arrival. CPR was initiated, achieved ROSC in the ER after receiving multiple antiarrhythmics, which include lidocaine, amio, esmolol, multiple shocks with, I think, about 30 minutes downtime. In the ER, echo with moderate biventricular dysfunction, structurally normal heart in the context of prolonged downtime. An ECG was unable to be obtained with an estimated QTc of 470 milliseconds on telemetry. Frequent PVCs were noted with coupling intervals of 300, 400 milliseconds that initiated runs of polymorphic VT. She was eventually transferred to the PICU, continued to have refractory polymorphic VT and VF, ultimately resulting in a death. And this kind of, this like more of a summary of all the things that I said. And I'll come back to this slide, but these are the tracings that I have of her, which are from the Zoll defibrillator. So you can see the PVCs initiating polymorphic VT and also VF. And with her, we did an autopsy, which was unremarkable. For genetics testing through a comprehensive panel showed an heterozygous VUS in triadin, which was determined as not clinically significant at that time. Following this, there was no family history of sudden death or cardiac devices, but although the family history was limited with the due to the not so long ago immigration from Ethiopia, the mother had a normal EKG, normal echo, normal exercise test. Father had normal echo, normal Holter, normal exercise test. Had T-wave inversion in his lateral leads, but that was about it. And so as part of the family screening, she had an older brother, a younger sister, and 3 younger siblings. So starting with the patient number 2, who's the older brother, it's a 19-year-old male who was previously healthy. And then this was the initial screening at the time of his sister's death. He had a normal EKG, echo, and his Holter showed occasional PVCs. And one of these PVCs he also had a single triplet in it. So I did an exercise test on him, and all his PVCs suppressed with exertion. He also got an echo, as I said before, which was normal. Didn't do anything for him for that. He then presented a year ago with sudden cardiac arrest during just standing in church. He had received bystander CPR. He had VF storm in an outside hospital, CVICU, put on VA ECMO, amiodarone, lidocaine, noted to have frequent PVCs. And once he got transferred to us, got a dual chamber ICD. And because of all his PVCs, we eventually transitioned him to flecainide and a calcium channel blocker because we felt his PVCs were short coupled at around like 300 milliseconds. On this therapy, he had an appropriate shock, and also during admission was having a lot of runs of polymorphic VT. And again, like he goes through periods of nothing, but then like he presented with these. And after we confirmed drug compliance and after failing increased flecainide, after speaking to Dr. Wiskin, Dr. Belhassen, we transitioned to quinidine and a calcium channel blocker. And he had no recurrence of VT or PVCs for the past 4 years. He has had a whole genome testing, which is negative. And he was also tested negative for the VUS that his sister had. And these were his presentations. This is just one of his PVCs. This is one of the non-sustained VT that he had while he was on flecainide before transitioning to quinidine. So this brings us to his younger sister, who's a 14-year-old female at that time, who was asymptomatic. And for her, her EKG, echo, and MRI were all normal without any LGE. Her Holter showed rare PVCs, but her exercise test was significant in that she started having frequent PVCs at peak heart rate. And so hers was a little bit more concerning. She did have separate genetic testing again done. She was negative for the triadin VUS, but then she had a Titin mutation, which was classified as likely pathogenic in the autosomal. It was autosomal recessive, so she was felt to be a carrier of it and not thought to be contributory to her presentation. She was initially started on Nadolol. I kind of, like felt that having to, like 2 people in her family like this offered ICD and even an ILR to be as a bridge to ICD, which she refused. Later on, during her routine testing with exercise testing, she started having non-sustained VT, refused ICD repeatedly, and ultimately was able to convince her to at least start on quinidine, along with a calcium channel blocker, but had poor compliance. And she, about 4 months ago, died suddenly in an outside hospital, unsuccessful resuscitation. We have limited history about it. And I don't know how big these are, but these are, like some of her exercise testing EKGs. This one was the first exercise test that she had, just showing the PVCs kind of, like starting to happen during peak exertion. This is one of her later exercise testing, which showing like some triplets. This is on an admission prior to us starting quinidine. Quinidine never really suppressed her completely, but it did make this like much less frequent. And the bigger question is, like now they also have like 2 other siblings who were 3-year-olds. Now they are about 7 and 5, who have had a normal echo, a normal EKG, normal Holter, a little bit young to exercise, but I've had them run wearing the Holter and has not had any PVCs. And so it's kind of a interesting family as to what to do. So I was curious on everyone's thoughts on 1, what diagnoses that you would consider in this family, and 2, I think the biggest thing for me is that, like how would you manage the younger siblings? And I have considered like placing ILRs, preemptively treating them with quinidine, but obviously knowing that comes with its own issues. And, like should I even start thinking about ICD placement, like beginning at some age prophylactically.
How much do you know about the parents, and have you looked at them with all of your detailed treadmills, et cetera?
Yeah, so as I kind of mentioned, the only thing that came out as being abnormal was the father's EKG with T-wave inversion. Exercise testing, they were, like fortunately we were one of the labs where we were able to do the exercise test in our facility. So, and both mom and dad's exercise testing was normal.
Have you, with the various tests coming back negative, you have one with a TRDN VUS and the Titan splice site. Have you collected blood samples? Do you have archived DNA from the deceased and this living one, and then the mother and father to basically start over? Because somebody, not you, but I don't know that the whole genome analysis has been done the right way, because this almost certainly, I mean, if you're going to have three siblings die, basically, you have an autosomal dominant monogenetic disease that's there to be found. And you wonder if they have, how have they done the whole genome sequencing in terms of in terms of the analytics.
Okay.
So I would be getting the mom and dad DNA, the archived DNA from the deceased, the living DNA, and having them run those 5 samples, not your 2 patients, the 2 not yet patients, the siblings, but those other 5 individuals, and basically doing a do-over.
Okay, gotcha.
Why do you say autosomal dominant?
Well, I'm just not gonna buy that we're 3 for 3 with an autosomal recessive mechanism.
Yeah, but betas are alive.
Yeah, but the dad does have a phenotype. I'd like to see what the dad's T-wave inversions are. I mean, that's maybe an endophenotype. I mean, of course, if we're doing the analysis, we run it through both an autosomal dominant scheme and an autosomal recessive. But for me, it just feels, how am I the odds of the 3 oldest all having the same thing from an autosomal recessive mechanism feels like a stretch. So I'd be leaning towards a dominant analysis.
Is there consanguinity?
No, that's something that we can have clarified with them, no consanguinity.
Clearly clarified not to be consanguinity, because I know that sometimes.
It's also like they are part of, they come from the same community.
Yeah.
So, like when they say no consanguinity, like, but also need to know like they are probably like closely related in one way or the other. So.
Okay, Ron has a question.
Does anybody know, is short coupled, I mean, they really do look like they're pretty monotonous, those PVCs, and then it is short coupled. Does that have a heritable component to it?
Short couple PVCs?
Clearly in this family.
So, so we were part of the registry data that Dr. Belhassan published on short couple PVCs, and I think ours was like the only family which was familial. In that, I think there has been like one other report and of like being familial too. So, but at the same time, it's been like I said, I've been like just stumped that we just couldn't find anything from a genetic basis, and just not knowing what to do for those younger kids. So.
This case sounds a little bit like a family I had at a prior job whose genetics came back with an RYR2, and the father who had cardiac arrest after eating lunch, and then a daughter who died suddenly texting with a cousin. The RYR2 was blamed, but it didn't really seem like CPVT. But in that investigation, DPP6, the short coupled PVCs leading to VF, it's not on the standard clinical tests. So depending on the coverage of the whole genome and your panel sense, DPP6 I think would be a candidate gene, but
we
would not have been
looked
covered.
for that
You looked
because there was a
specifically.
case report on that particular gene, so that's something that we asked them to look for.
That's a great idea, but I think the family needs sort of a whole genome sleuthing do-over.
Okay.
In terms of the 3-year-old, and I personally would be doing a periodic Holter and until and unless they exhibited for me an offending or concerning PVC, I would be leaving them alone.
Okay.
When you guys say genome do-over, who do we send that to? How do you get that done? And who do you trust? I mean, I know people that I do trust, but
Yeah.
I mean, I don't want to run to the same, half dozen people every time I have something I can't figure out.
With a couple options, I mean, some programs have their own clinical genomics diagnostic odyssey cases now, and that they do it under a clinical genome. That's probably the fastest execution. I don't know how good they are at thinking outside of the box of the rubric of the analytics though. So that it's, Dr. Miyake's I Hope kids would be this type of trying to solve this arrhythmia odyssey. I mean, that's what I think her hope is with that registry. Other programs where that's what we've done in our molecular autopsy program is that's what we do. And so there are research labs that are committed to doing that. The problem with the research labs, ours, is the yield is so low. And so it tends to be on the, yeah, we'll get to that genome when we get to it. So I think the pace is pretty slow in the research mode, just because it's pretty clear that, if on first pass you're not finding it, the likelihood of finding the aha is just, even as we know with a pedigree that's unbelievably rich, if you're not finding the obvious miss, a deep intronic, something in your gene of interest or whatever, it's just really hard to find it. But that's the only option you have. You've got 5 people, potentially
Yeah.
5 DNA sources. You have 3 clearly affected, and you could presume that perhaps the dad is the endophenotype positive one. And you could subtract everything inherited from the mother and see what the 3 siblings and the father all share in common, and then see if that reveals something of interest.
So the only one other thing that we kind of discussed with our genetics team is kind of creating like a pluripotent stem cell model and trying to like see if you can induce VT, and then use that to study the other 2 kids, but obviously way out of my area of expertise, and was
Yeah,
probably out for our team as well. So
Yeah.
is that something
That's not going to work.
Okay.
No, I mean, because what you need is you want in your deceased case, your case with disease, you can get their induced pluripotent stem cells and re-engineer into the cardiac cells, but you're going to have a monolayer. And if you don't have a endophenotype of QT prolongation or short QT interval, the cells aren't going to give you anything. The cells are terrible as a model of VF. So you're not going to get a cellular example of short coupled PVC triggered VF. So I don't think that that's gonna help you. I personally would start with the
Okay.
a genome of the 5 people. And there would be places that I'd be happy to try to partner. And the answer of where do you do it, it all depends on what's the strength of the pedigree. I think clinically, what we prefer would be doing is doing a whole genome sequencing clinically when there's no family history, no nothing, with the hope that a simple de novo variant emerges that gives you a fast answer. But if you don't get that fast answer, usually the answer is there's no answer.
Yeah.
Yeah, but I mean, it is measured then in years,
Question here.
I totally agree with Mike's approach of start all over again and do a whole genome. But one other gene to just check if it was appropriately interrogated in what you've done so far is PPA2.
Okay.
Autosomal recessive wasn't on the panels until very recently, but it's turning out to be, it's still rare, everything's rare, but a decent cause of multiple SIB sudden death like this. PPA2.
Andreas.
So I just had one question regarding, would you ever think about ablating any of those triggering topics?
So the 19-year-old guy, I think, he was almost close to getting an ablation, but, since the quinidine just worked so well for him, it just deferred. But that is kind of, what our next hypothesis, next step would be if he kind of either doesn't tolerate it or if he has more shocks on quinidine.
That doesn't change the course, but it helps the sites.
Yeah.
Very.
Thanks.
Okay, thank you. Okay, last case, Chris Anderson from Spokane. We have 20 minutes.
Okay, great. All right. Thanks everybody for hanging in there for the entire afternoon. It's a pleasure to be here, and thanks to AJ and Balaji for inviting me to present this patient who I think is a very compelling case for the end of the day, and hopefully not quite as complex as some of these others, but and finally, thanks to the 4 prior speakers for helping us work through all the technical difficulties. So this is a case of an asymptomatic 14-year-old boy who came for an evaluation more than 2 decades ago to our clinic following his brother's sudden death while riding a motorcycle in a motocross competition. And this was a very interesting event in that there were several who observed the sudden death. And what happened is the brother was on his motorcycle and just literally slowed down upright, stopped, and his motorcycle tipped over and he was in arrest. The unfortunate part was it took 7 minutes for rescuers to get to the scene and start CPR. And when he was finally connected to a defibrillator, the indication was an unshockable rhythm, but later analysis showed fine V-fib. His autopsy was unrevealing, no molecular autopsy was done. There was also family history of some congenital heart disease that we felt was unrelated. Both of the boys' parents had normal ECGs themselves, and our patient's exam was normal. This is his ECG presentation, and again, this is over 20 years ago. It's been scanned into 2 different EHRs since the original recording, but my interpretation was pretty normal appearing, normal sinus rhythm, and the QT interval that I calculated corrected at 425 milliseconds. And another ECG performed within that same month of presentation is on a little bit better grid. And this one also looked fairly normal, except I did note that there were some prominent U waves, especially anterolateral precordial leads, and that this time the corrected QT interval measured 470 milliseconds. So any thoughts from our panelists or audience?
Okay, keep going.
Okay. So we did a very thorough workup on our patient, included a normal echocardiogram, a normal 24-hour Holter, and I apologize that I don't have this tracing, but he did have an exercise treadmill test which showed a few seconds, approximately 6 seconds of a rapidly conducted atrial fibrillation near peak exercise up to a rate of 240 beats per minute. And what I did note was that the QRS at this time was just slightly wider. I didn't think it was pre-excited AFib, but I was suspicious enough given the family history to want to do more. And so we went ahead with a diagnostic electrophysiology study, and I pretty much did everything: AFib induction, isoproterenol. We went through all of the protocols for programmed ventricular stimulation, and really the only pertinent finding on this EP study was that his corrected QT interval was quite a bit longer on isoproterenol, from a very short baseline of 386 milliseconds to up to 496 on isoproterenol. And over time and follow-up, we started him on metoprolol. If it had been a couple of years after this, we would have switched him to nadolol to treat atrial fibrillation, I guess. And he had additional ECGs over the course of his follow-up with a longest corrected QT interval of 470 milliseconds, which was on that ECG that I showed you. And multiple times over the course of this workup, we recommended genetic testing. And this was still in the era where it was hard to get commercially available testing or testing in a research laboratory. And so that did not happen. And eventually, we cleared him to participate in sports and on beta blocker. He poorly tolerated the metoprolol, and with a dosage adjustment to a very low dose. 1 week before his 16th birthday, he had sudden cardiac arrest while basically standing mid-court during a game while another player was doing a free throw. He reported a prodrome of lightheadedness, dizziness, blurry vision, and this time the response was quick. Within 1 minute, he had CPR ongoing. A physician in the stands was able to help with that. An AED was retrieved and appropriately shocked for course VFib, and he converted on the first shock. Full neurological recovery. Again, still over the course of his post-arrest evaluation, nothing too remarkable. Borderline prolongation of the QT interval up to 470 milliseconds. CMRI just showed a little bit of mild LV dysfunction post-arrest, same with echo. And he had a dual chamber transvenous ICD implanted and was sent home on a slightly higher dose of metoprolol. So at this point, just a show of hands, how many think this is Brugada syndrome? Okay, good. How many think it's catecholaminergic polymorphic ventricular tachycardia?
Hey, Chris, can I ask, and I realize a long time ago, you may not remember, at the EP study, when you gave isopril, did you do sort of aggressive atrial pacing as well?
I did not, and I've been back and forth about this, but when I induced AFib, it was under baseline conditions, and there was no evidence of an accessory pathway.
Well, no, so just because the patient had short runs of AFib during the exercise test with some aberrancy, and I wonder, so option B is CPVT, and of course CPVT, a supraventricular arrhythmia can suppress the VT. So, it might have looked a little funny. And sometimes in patients that are too young to exercise in the lab, we'll give isoproterenol and do atrial pacing, and that can actually induce polymorphic VT. So that's why I asked.
Yeah, that's a great point. What about early repolarization syndrome? Not really. Long QT syndrome? Or idiopathic ventricular fibrillation? So we got one vote for idiopathic VF. Excellent. The two main diagnoses I was considering, these were just my own thoughts, were CPVT and long QT syndrome, but I too did not feel like there was a clear diagnosis. I felt that he needed genetic testing. So on follow-up, the patient developed clinical depression and exacerbated by PTSD from multiple shocks from his ICD during atrial fibrillation inappropriately. Not long after this, he transferred care to another center where he was diagnosed with a clinical long QT syndrome, and propafenone was added to his antiarrhythmic therapy, which actually controlled his arrhythmias quite a bit better at that point. And fast forward more than 10 years later, finally, genetic testing was performed, which returned 2 heterozygous TECRL at the initial time variants of unknown significance. One of those was later reclassified as pathogenic. The second was later reclassified as likely pathogenic. And the diagnosis was later changed to CPVT at that center. The next question I wanted to ask, this is a select all that apply. Which of the following are true regarding TECRL and TECRL related disease? For those who are unfamiliar with TECRL, it stands for trans 2,3-enoyl coenzyme A reductase-like protein. Great to call it TECRL. Can TECRL cause both loss of function and gain of function mutations that have been found? I see at least one nod. And nods from our expert panel. The phenotypic expression of TECRL may mimic CPVT, true or false? True. Can it mimic the phenotype of long QT syndrome, true or false? Lots of nods there, good. True or false, TECRL related disease is most commonly expressed in an autosomal dominant manner. Yeah, the expert panel has it. It's typically either autosomal recessive or you can have compound heterozygous mutations. And then finally, does the gene product of TECRL localize to the contractile apparatus, or where does it go? Where is it in the cell? Yeah, the endoplasmic reticulum. So it's not part of the contractile apparatus. I didn't really know anything about TECRL. I still am certainly not an expert, but it's definitely been reported to have phenotypic overlap with long QT syndrome and CPVT, and also expressed with atrial fibrillation and other malignant ventricular rhythms. And when it's homozygous or compound heterozygous, it's a very high risk arrhythmia substrate. And so, you know, at this point in time, I think we have a clear genetic diagnosis to go along with this patient's presentation after many long years of waiting. But we also have this patient's two sons who have now come into our care, and Xander's in the audience and knows, I think, what the status with their genetic testing is. And so one question I would really love to ask the expert panel is TECRL disease different than long QT syndrome and CPVT, and should it have its own sort of diagnosis attached to it? And maybe I should just get your perspective on that before I ask another question.
Yeah, I think it should. We would refer to it as TECRL mediated arrhythmia syndrome. So rather than trying to make it, it's not a pure long QT, it's not pure CPVT, but what, 15 years ago, I'm really impressed, Chris, with what you thought, because I think when you're encountering a patient where you're thinking that it could be CPVT or long QT in a family structure, that gives you a narrow list, because most long QT patients and families, you never have to think about CPVT and vice versa. But when you find yourself thinking those two entities as the explanation, that's a pretty short list now. It's the calmodulinopathies, it's triad and knockout syndrome, it's TECRL, and it's KCNJ2 Anderson-Tawil, where some Anderson-Tawils have QTU issues, some have CPVT issues. And so I think for the younger, is if you're thinking both of those diseases in the same family structure, those are the four ponds to go fishing in. And then you nailed it with this TECRL, which it's easy for the next generation because his boys are going to be heterozygous carriers and zero risk, basically.
And thank you for that, because that was my next question. So if they are heterozygous,
They will be. So every child he's created will have one or the other.
Unless he married somebody who also happens to be homozygous for TECRL, right? Isn't very common.
Okay.
So I tested the partner and she's negative, so I haven't done anything further for them, so.
Perfect, yeah. So, Chris, I'll say, so Zahir Bouyan is the one who sort of first found families with TECRL, and it was more predominantly CPVT than long QT in terms of the phenotype. And he actually first found it by linkage, and it took forever to find the gene because it's a gene that nobody really thinks about in terms of a channelopathy. And it's interesting that the proband did very well after being put on, I think, propofenone and a beta blocker, right? And so the therapy seems to be more directed towards CPVT. And so I think that's probably the way we tend to treat these patients. I personally have no TECRL patients, so I don't know, but that seems to be more the sense of the literature, that they act clinically more like CPVT than long QT. They have mildly prolonged QT intervals, and so it is sort of an overlap syndrome.
On the proband, did you have the ability to test the parents? Like, did both mutations come from one parent, or did one come from the mother and one come from the father?
Yeah, that's a good question. I think it was one from each, but I don't think we actually have their genetic testing. Do we, Xander?
I think one was from the father and one from the mother from the records, and have the actual things, but going back into.
I mean, basically it has to.
Yeah.
So now it could be that one was parentally inherited and the other one was de novo, but it would require that the de novo one happened on the other allele. Because if it's all on the same allele, then you are just heterozygous. And it still would be a null phenotype or not a phenotype.
Anybody else have a patient of TECRL? Andrew? No?
We dug into the literature and there's very sparse case reports. There's, I think, maybe 3 or 4 case reports. One of them reports on 3 patients. One was, there was, actually, I think with 2, there was consanguinity. And with a 3rd case, it was just bad luck, inheritance pattern. But it is very rare. And hopefully we'll learn a lot more about this disease with time.
Did you have a
Maybe
positive
more.
stress test, Chris? I missed that in terms of, did the stress test show CPVT-like ectopy or not really?
Only a very short run of about 6 seconds of rapid atrial fibrillation, and that was it.
Yeah, so it's kind of interesting that it's gotten lumped as CPVT-like because in the future, the overlap with TECRL is probably going to be more CRCDS-like because the TECRL mutations in the IPSCM models, they don't produce a gain of function of ryanodine receptor behavior. Actually, there's about a 50% loss of RYR2 and a 50% loss of junctifillin, which now brings you more like what CRCDS is behaving like. And so it's kind of interesting that the stress test really won't be CPVT-like. So the overlap probably is going to be QT prolongation, sort of with isopril, and more CRCDS kind of mimic.
Sorry, what is CRCBS?
Calcium release channel deficiency syndrome.
I know that Mohammed Ibrahim from Kuwait had a case like this and put it on YouTube somewhere. And Andrew, I think we discussed this at Children's Heartbeat one time. Can't remember the details, but again, a very malignant story. I think it's on YouTube from Mohammed Ibrahim. Well, I'll let somebody else finish this up. I think Alejandro.
You're done holding your microphone? All right, you've dealt with enough of me trying to troubleshoot this stuff over here. Thank you all for coming. Thank you for the panel of experts for sitting up here and staring at tiny screens and tiny EGMs and EKGs for a few hours. Hopefully I fed you enough cookies and gave you enough coffee. Thank you for the SADS Foundation for hosting this event and to the folks over in that corner. And thanks for coming to San Diego. Welcome to San Diego. I hope you have a great time the rest of your trip and your stay here. And head on out. It's been a long enough day. See you all around town.